Now, this is a picture of Nigel Crisp, who for several years was chief executive of the National Health Service, which employs 1.3 million people and is one of the world's biggest health services. And when he left that job, he travelled the world thinking how the NHS in Britain could help more with global health. And he wrote what I think is a very interesting book that I would recommend to you, called Turning the World Upside Down, The Search for Global Health in the 21st Century. And one of the things he argues in his book is that public health has been to some extent eclipsed by the success of clinical medicine, and that it's the time to reverse that. So he says, despite its successes, public health has become the junior partner to clinical medicine and has been less powerful and less well funded. It was really together with clinical medicine until the early 20th century, so Redfern was both about public health and clinical medicine. And he says that that's when, in some ways, the decline began. Public health has, over the years, revived and reinvented itself, but has never quite managed to link itself sufficiently to the scientific establishment and commercial interest to challenge the hegemony of clinical medicine. I rather like that phrase, the hegemony of clinical medicine. But, he says, now with the emergence of global health as a new discipline, it's once again being viewed as of enormous importance, and that's really what I'm trying to argue today. The core of Crisp's argument, and I reviewed his book for the BMJ if you want to read briefly about it there, is that really health systems are bust in both rich and poor countries, and that it's time for something new to arise. In fact, it's time to turn the world upside down. Our systems at the moment are dominated by hospitals and what I call the 4 Ds: doctors, disease, drugs, and death denial. It worked well in the 20th century, is Crisp's argument, but now we need something different. We need to move from doctors to patients and perhaps other kinds of health workers, including community health workers, from disease to health, from drugs to other kinds of non-drug interventions, and from denying death to recognizing death as a friend, as it is to all of us at the end of life. Crisp in his book points out that Africa at the moment has 25% of the global disease burden, but only 3% of healthcare resources and 1% of health workers. North America, in contrast, has only 3% of the disease burden, but 25% of healthcare resources and 30% of health workers. This is an extreme imbalance. And Africa's predicament is clearly unacceptable, but so, argues Crisp, is that of North America. Its doctor and hospital-dominated healthcare system, designed largely for an age of acute care and infectious disease, is inappropriate and increasingly unaffordable. And poor countries do not need a dilute version of what rich countries have now. They need something different and much more emphasis on public health. And ironically, poor countries may actually have an easier time moving to a better kind of health system because they do not have they don't have to counter the huge vested interests that there are in existing systems in rich countries.